Okay, so first thing we're going to deal with here is shock. Okay, and there's some things that will lead to shock. All right, and that would be heart failure. Okay, bleeding out. Okay, that would be, in fancy terms, that would be hypovolemia. Okay, and vasodilation. So that's where the tubes, your blood vessels, go from, let's say, that big to the diameter increases. Okay, so vasodilation. All right, when these happen, okay, when all this happens, you're going to get a pretty significant decrease in cardiac output. Okay, so this becomes part of the key here. So this decrease in cardiac output. Now what happens with that is you're going to get a decrease in oxygen to the cells, to tissue, and to organs. Okay, so this decreased oxygen is basically hypoxia. Okay, and then hypoxia causes a bunch of problems. Okay, so it will decrease your calcium pumps. Okay, it decreases in ATP production, right? So no oxygen, and this is due to decreased oxygen, right? So you want to decrease ATP production, don't get oxygen into the mitochondria of cells. Okay, and ATP is our fuel. All right, so when this all happens, then you're going to have a decrease in your sodium potassium pump. Okay, and then that leads to an increase in lactic acid buildup. Okay.
Emily Hurley's still in the waiting room. She's trying to get in. She wanted me to let you know.
Okay, hold on. Okay. So remember the goal of angiotensin 2 is to cause vasoconstriction. All right, you can also get nitric oxide. So too much production of that, that's a vasodilator. Okay. All right. And all of this can lead to cell death. Okay. Okay, so shock and hypotension. Okay, so this is going to be decrease in blood pressure. Okay, so when the body detects a decrease in blood pressure, another way of saying that would be a decrease in circulating blood. Okay, which is your hypovolemia. Okay, now typically, by definition here, this is going to be blood loss of 25% or more. Okay. And this number is usually when shock starts to set in. Okay, so at 25% hypovolemia, it's when shock will start to set in. Okay. Other factors to consider is dehydration. Okay, so water loss and salt, so sodium loss. Okay, one of the reasons why you do a saline solution, try to get them hydrated to get the volume back up. Okay, because the person is currently experiencing hypovolemia. Okay, so hypotension. All right, so typically this is the stimulus, okay? So keep in mind when your body is experiencing something, that would be the stimulus. So I currently have high blood pressure, okay? So that's the stimulus. What's the body going to do to compensate? I'm currently experiencing low blood pressure. Okay, that's the stimulus. What's the body going to do to compensate? I currently have not enough calcium in my body. Okay, that's the stimulus. What's the body going to do to compensate? I'm currently cold, right? So that's the stimulus, and how's your body going to compensate? Well, it might shiver. You shake the muscles, that helps warm you up. All right, and so on. So there's always a stimulus that causes the body to try to compensate. Okay, so the stimulus in this case is going to be hypotension. All right, so then the goal is to increase the blood pressure. Okay, so your body can do that on its own, and if it can't, then that's where the ER team comes in to try to help. Let's get things stable again. Okay, whatever the case may be. So, hypotension. The goal would be to increase the blood pressure. All right. So, uh, as far as your body's concerned, okay, um, you activate the baroreceptors. All right, so those are located in the carotid sinus and the aortic arch. Okay, that would have been an ANP2 thing. Um, so you can write that down. So the baroreceptors are located in your carotid sinus and the aortic arch. Okay, but these become activated. And you also will activate your sympathetic nervous system. Okay, so when you see the sympathetics, you should automatically think um, epinephrine, norepinephrine. Okay, this is fight or flight stuff, right? So then your usual suspects of sympathetics kick in, such as uh, increased heart rate and increase um, the force of your heart contraction. Okay. And when you get these, right, which by the way, that's stroke volume. Okay. So when you get increased heart rate, increased stroke volume, that creates an increase in cardiac output. Okay. When you increase in cardiac output, that can increase blood pressure. All right. Another route your body can take to increase blood pressure would be through the RAAS system, right? The renin-angiotensin-aldosterone system or mechanisms. All right. So when this becomes active, okay, its bottom line goal is to increase vasoconstriction and to increase blood volume. Okay, and the way it does this is through what's called a decrease in kidney perfusion. Okay, perfusion is a fancy word for you're going to decrease in fluid loss. Okay, so if there's too much perfusion, you're losing too much fluid. If there's decreased perfusion, you're keeping fluid. All right, so, and by keeping fluid, you are increasing the volume, right? So if your body is retaining fluid or keeping fluid, that's going to increase your volume, okay? Now, at some point within homeostasis, like this is good, you know, you want this, but sometimes this spins out of control, okay? So that, you know, in the shock family, all this would likely be spinning out of control, okay? And the weird thing about shock is sometimes you don't know which way it's going to go, right? This person has massive vasodilation, massive decrease in blood pressure, right? Then all of a sudden something happens and massive vasoconstriction kicks in and blood pressure shoots through the roof. Okay, cardiogenic shock. Okay, cardiogenic shock. All right, things that can cause this would be the right and or left ventricular dysfunction. Okay, right or left ventricular dysfunction, or I should say right and or left. Could be one or the other or both. Okay, could be because of a myocardial infarction, which is the most common. Okay, this is usually where the heart is experiencing a greater, I guess you could say, greater or equal to a 40% decrease in function. Okay, so in other words, the heart is experiencing 5% dysfunction. Okay, probably not cardiogenic shock. But as the numbers keep creeping up, and once the heart starts to experience 40% dysfunction or greater, right, 50, 60, 80%, the bigger the number, the worse it is. This is where you start getting into your myocardial infarction family of things. Okay, and another one could be just different cardiomyopathies. Okay, so cardiomyopathies is just some sort of dysfunction of the heart. Okay, and these are things that can lead to cardiogenic shock. All right. Let's talk about a few other things about it. Okay, so if the heart has decreased cardiac output, okay, that means the pump, okay, so your heart is a pump, right? So the pump is not pumping correctly. Okay, and if that's happening, if it's not pumping correctly, you're going to have decreased blood flow, which is going to lead to decreased oxygen to tissue, to cells. okay, which, you know, in the long run is not good. And then back what we wrote earlier, you get all these toxic buildups, you get the lactic acid, you get all the, you know, the inflammatory response, okay? All right, so this decrease in cardiac output is because the heart's not pumping correctly. And the left ventricle, so you're going to have an increase in the left ventricle, quote and unquote, filling. Okay, so that means there's, you can kind of look at it this way, too much fluid, which is blood, okay, getting into the left ventricle. And what this means is you're going to have an increase in the preload. And when that happens, you get an increase in the diastolic or diastole. Okay, and diastole is the bottom number. So like your normal average would be like 120/80. So the top number is your systolic, and your bottom number is diastolic. Okay, so the diastolic number goes up. All right, and keep in mind, one way of looking at systolic over diastolic, systolic is ventricular contraction, and diastolic is ventricular relaxing, which means it's filling with blood, right? So when the ventricles are relaxing, they are filling with blood, and when they contract, they eject blood. Okay, so if the left ventricle keeps filling too much, you know, it's going to change, right? So the diastolic pressure will change, and, you know, that's not good, okay? So this left ventricular preload okay, this increase in the preload it leads to movement of fluid from the pulmonary vessels okay, so from the pulmonary vessels to the pulmonary interstitial space. Okay. And so in other words, you're getting fluid in the lungs where it doesn't belong. Right, you're getting fluid into the lungs where the fluid does not belong. All right. So once fluid starts to get into the interstitial space, then fluid is going to start to get into the alveoli. Okay. And when that happens, when fluid gets into the alveoli, then you're going to have a decrease in gas exchange. All right, such as a decrease in oxygen, for example. Okay. And then once the body experiences that whole hypoxia stuff, then you're going to activate the sympathetic nervous system. And with respect to shock, you get the usual suspects, right? So that is going to include so activation of the sympathetics. And now you're going to get the increased cardiac output, okay, which increases heart rate, which increases the heart load, okay, which activates the RAAS, okay, and when you activate the renin-angiotensin aldosterone mechanism, remember that increases vasoconstriction. Okay, so when that happens, you get an increase in peripheral resistance. Okay, because the tubes went from big to small, and it's really hard to push blood through small tubes. So you get an increase in peripheral resistance, and then this creates more heart damage. Okay, so these are fun stuff that comes with cardiogenic shock. Okay, so some other things that are going to come with the cardiogenic shock. So, all right, so signs and symptoms. Okay, so signs and symptoms of all this. All right, so normal heart sounds, right? So your heart sounds normal. You should hear an S1 and an S2 heart sound, right? The lub, dub. Okay, so typically it's a lub dub, right? When you're listening to the hearts. Well, with conditions, with abnormal findings and all that, you can hear an S3 heart sound, an S4 heart sound. So usually one of the auscultating, okay, one of the auscultating signs and symptoms okay, you're going to hear an S3 sound, which is gallop. Okay, so it gets the word gallop because of the way a horse, when a horse is galloping, that distinct sound the hooves make when they gallop. All right, so it's kind of where they get it from, just has a different sound. It's definitely not an S1, S2, really pretty heart sound. There's an extra sound in there. Okay, so the S3 sound, gallop. And this is, gallop usually happens due to an increase in that left ventricular preload. Okay. All right. Usually when this happens, well, let's go back up here. So another sign and symptom, um, the systolic. Okay. The systolic will actually decrease in its number, and that diastolic increases. Okay. And because diastolic is decreasing, this is going to narrow or diminish the patient's pulse. Okay, so like let's say you're palpating the radial artery or the carotid artery, it will be very narrow or diminished because of a decrease in pressure, right? So the systolic, remember systole is where the ventricles squeeze, right? So if the pump squeezes and it's forcing fluid into tubes, you should feel that pulse against the tubes. Tubes meaning the arteries, right? So like easy ones would be radial and carotid artery. But because the systole is decreasing, then you're really not going to feel much bounding against the arteries. Okay, so you have a narrow pulse pressure. Okay. Also, with other signs and symptoms, okay, they're going to have tachycardia. Okay, so rapid heart rate, usually defined as greater than 100 beats per minute. Okay. In the lungs, because of that pleural effusion and edema, you're going to have an increase in sound for crackles. Okay. And that's because of the edema. And you can get vasoconstriction. Okay. And when you have vasoconstriction, then the skin or the patient and the skin can be cold, clammy, pale. Okay. And then other signs and symptoms can be hypoxia or hypoxic. Right, your hypoxic effects, so things that come with the decreased oxygen package. Okay, they can turn blue, cyanotic, you know, the the toxic buildup, decreased ATP, all that stuff, right? Stuff we listed before of usual suspects that come with decreased oxygen or hypoxia. Okay. Cardiac shock. Well, this cardiac shock treatments, I guess I didn't need that. Okay, so treatments. Okay, first of all, these can be difficult to manage or to treat. Okay, and that is due to myocardial cell damage. Okay, I mean, there's limitations to matter, right? I mean, you can only do so much to help someone. Have a lot of cool technology, a lot of neat stuff that can help people, but even, with all the fancy stuff, there's still limitations to matter. So you're still subject to how much or how little cell damage has taken place. Okay, when enough has happened because of limitations to matter, this is usually not reversible. Okay, but the goal, and that doesn't mean you necessarily give up, right? I mean, do everything you can. So the goal is to increase oxygen. Okay. And other things like increased circulation, increased blood volume. And then they can do that. This is just a few things, this is not an exhaustive list, but as far as drugs, okay, things that would promote or activate vasodilation if they're under vasoconstriction, to decrease the preload to the ventricles. Okay, hydrate the patient. Okay, if needed. All right. Okay. Let's actually take a little break. We still have obstructive shock and hypovolemic shock and distributive shock and other forms of shock to cover. Okay. So any questions or comments or anything before we take a 15-minute break? All right. So when we come back, we'll start with obstructive shock and take some more longhand notes. Okay, so I'll see you all in 15. All right. So the next thing we'll look at is obstructive shock. Okay, so this is a result of decrease in the heart pumping due to a mechanical obstruction. Okay. So an example would be pulmonary embolism. And cardiac tamponade. Okay. Okay, pulmonary embolism would be, basically a blood clot in the lungs. Okay, kind of an easy way of looking at it. So if this happens, then the person will experience dyspnea. Okay, which is shortness of breath. They'll have an increase in right side heart pressure. Okay, and that's because the right ventricle is responsible for ejecting blood to the lungs. Okay, so you're going to have some backup. And when you have backup, like something is clogged, the tubes are, let's just kind of put it simple, the tubes are stuck, right? There's something obstructing it, so it's clogged, and there's fluid continuing or continually trying to get through, but it can't. So the pressure on that right side usually goes up. And when that happens, then you're going to have the wonderful decreased oxygen. Okay, the cardiac tamponade is increased fluid in the pericardial sac. Okay, so back to your heart anatomy, you've got the 4 layers to the heart, right? The outsidemost layer is the pericardium, okay? And then you have the next layer in, which is the epicardium, okay? Then the myocardium, then the endocardium, right? The myocardium being the muscle. Okay, there's a space between the pericardial the pericardium and the epicardium, right? There's a space there that's filled with fluid, okay, a type of serous fluid. And that fluid that is around the heart is normal, right? So it's normal to find some fluid in between the pericardium and the epicardium, okay? However, in this case, you get excessive fluid, right? So increased fluid in the pericardial sac or pericardiac or cardiac tamponade. And because of the increased fluid, this is actually going to increase the pressure on the right and left side of the heart. Okay. So as a very simple analogy, it's like taking both of your hands and just squeezing the heart. Okay, you're just applying this pressure over the heart, and the more that you squeeze, the more you're constricting, the more pressure you're putting on the right and left side of the heart. But in this case, it's the fluid doing it. Okay. All right. So essentially, the heart feels like it's being crushed. This increased pressure would be crushing in on the heart. All right. And then the goal with obstructive shock is to remove the obstruction. Okay. Next one is hypovolemic shock. Okay. This is a decrease in blood or fluid supply. So a decrease in blood or fluid supply. And typically, by definition, it would be greater than 20% um, total body fluid loss. Okay. All right. When this happens, you risk decreasing blood volume. Okay. And then when you have a decrease in blood volume, you have a decreased ability to perfuse tissue. Okay. And the perfused tissue means the passage of fluid through the circulatory system. Okay. So your body's ability to pass fluid through the circulatory system. Okay. And then when this happens, okay, when all this happens, you get hypoxia or decreased oxygen. Okay, then usual suspects come with the decreased oxygen, all the stuff we mentioned earlier. Okay, so some causes. Okay, for all this could be hemorrhage. Okay, so you're bleeding out, so hemorrhage. Okay, we'll come back to that because there's some other things I want to build on. Another one can be burn victims or burns. Okay, so remember, part of this hypovolemic shock is decrease in blood or fluid. Your skin, right? So your integumentary system is a barrier. Okay, so it keeps the bad stuff out of your body and keeps the good stuff in, right? It's a barrier. So burn victims lose the ability to retain fluid, right? So they can lose a lot of fluid because of if the burns become too significant. Okay, and I'm not talking about, you burned your finger on a little candle. These are usually a great percentage of the body with burns. Okay, another one could be prolonged vomiting. All right, diarrhea. Okay, which is also a lot of fluid loss. And then diuresis. Okay, and diuresis is where the kidneys well, let's just say losing too much fluid. So you pee a lot. Okay, you pee too much. All right, diuresis. Okay, so all of these lead to loss of blood and or fluid. And when that happens bad enough, right, you are now in hypovolemic shock. Okay, the vomiting and the diarrhea thing, have to use a little bit of intuition on that because that is actually part of our innate immune system, right? So in other words, if you eat bad chicken or something not good gets in your system, you actually want your body to throw up. Okay. So there's kind of a reasonable amount of, vomiting because of illness. And same with diarrhea, right? You get, cryptosporidium or Gerard, whatever, these different uh, infections that can cause the runs. At first it's okay because it's your body's way of purging, but then at some point it crosses a line, right, where it can become dangerous. Okay, so some intuition. To piggyback on that, fever is another one, right? So if a person has a fever, that is your body's way of fighting whatever it is it needs to fight. But if the fever spins out of control, gets too high, or is too, happening too long, then intervention is necessary. Okay. Um, so that's where we get these why it's important to have some references like greater than 20% of your body fluid loss. Okay, that will help. All right, back to the hemorrhage. Okay, so this one has 4 stages. Okay, and they list them class 1 through class, class 4. Okay, class 1 through class 4. So then that would be 2 and 3 and then 4. Okay, basically class 1 is minimal, and then class 4 is the worst. Okay, so class 1 would be minimal blood fluid loss, which is about 15%. Okay, stage 2 is blood fluid loss at about 15 to 30%. And class 3 would be blood or fluid loss 30 to 40%. And then class 4, which is the worst, would be blood or fluid loss greater than 40%. Okay. Okay. Treatment. All right, so treatment would be to control blood loss. Okay. And then we'll come back and do some signs and symptoms. Should have done signs and symptoms first, but that's okay. So treatment would be to control blood loss, replace fluids, okay, and you can replace fluids through colloids, okay, which helps increase osmotic pressure. Okay, you can do it through crystalloids. Okay, these contain electrolytes. And you can do it through transfusions. Okay. Okay, now keep in mind a transfusion is where you give any kind of blood product. An infusion is where you give anything else. Okay, through IV or injection or whatever, right? So Transfusion would be blood products, such as giving like red blood cells, get their hematocrit level back up, which will also help osmotic pressure. All right. Signs and symptoms. Okay, decreased in cardiac output. Okay. Decreased pulse. Cold, clammy, pale, cyanotic. Okay. A decrease in pulse ox. Right, so decreased oxygen. Right, so usual suspects that are going to come with shock and hypovolemia and fluid loss, blood loss, right? These are fairly common signs and symptoms. Okay. Distributive shock. Okay. This one's a little different. Okay. So first, let's start with it is excessive vasodilation. Okay. So the tubes went from this big to this big, right? So excessive vasodilation. All right, so when this happens, you're going to get increase of pooling of blood in the body. Okay, and more specifically, this happens in the veins. Okay, this will happen in the veins. Right, and so this one is deceiving. Okay, so be careful because it gives the appearance it gives the appearance of hypovolemia. All right, but it's kind of not because they didn't lose any fluid. Like the fluid didn't leave their body like you would expect from hemorrhaging. Okay, so the fluid is kind of hiding out, so to speak. So just be careful on this. Gives the appearance of hypovolemia. Now veins, they are very expandable. Okay, so when you compare a vein to an artery, right? Veins are more flimsy and more collapsible. They're kind of like a balloon. You know, you can, if I give you a balloon, tell you to blow it up, right? This balloon skin, which was all deflated. I mean, you can push massive amounts of air or fluid if you want to make a water balloon, right, inside of the balloon, and it just expands. Okay, because veins are very elastic like that. They can expand quite a bit. So this pooling of blood in the veins is what's causing that. Okay, so when this happens, then you're going to get decreased oxygen to the brain and cells, okay, and tissue. All right, and this is due to a decrease in the preload and stroke volume. All right. Let's go back up here. Okay, another one would be profound hypotension. Okay, profound hypotension. So a significant drop in your blood pressure, right? Probably numbers like 60/40, 50/30, you know, that kind of thing. Really, really low blood pressure. Okay. And then okay, so here's a 3 subcategories of distributive shock. All right, so we have anaphylactic. Okay, anaphylactic shock. All right, and this is your, right, so anaphylaxis, right? The throat swelling, severe allergy response. So let's say, okay, severe allergy response. Okay, severe swelling. And you're worried about, you'll be, excuse me, you would be worried about the throat, so decreased airway, right? That would be a concern. Okay. So this is usually because of an increase in IgE. Okay, and other inflammatory cascades of events, right? And they all kind of feed off of each other, taking a bad situation worse. Okay, so treatment would be things like the EpiPen. Okay, And then more long-term care, and this is actually some of the stuff I do, is figuring out what is provoking the person. Okay, so so like I do immunoglobulin testing. More specifically, it's antigen, antibody testing. Okay, and you are looking for things like the IgE, IgG response, IgG4, C3ds, okay, blocking potential. All right, so that gets into some other topics, we're not going to really talk about right now because that gets very detailed. But the quick version is you can test a person to see what their body is allergic to and or sensitive to, and this one is the main one. Okay, so and you can do this for just about anything. It's an antigen antibody test, and you're looking to see if their immunoglobulin E's are, shall we say, spinning out of control if you consume whatever it is that is causing the problem. Okay, so let's just pick on peanuts for right now. It could be anything. It really could, right? So let's just pick on peanuts. So if a person has um, an abnormal immunoglobulin E response to peanuts, right? The presence of peanuts, it just devastates them, right? The cascade of inflammatory events is kind of ridiculous and it can be life threatening. Okay. Um, so, one thing that can help as far as treatment is to teach the patient, to teach the person what to stay away from, right? Now, sometimes it's trial. I don't mean to laugh at it, but sometimes it's trial and error. Okay, got stung by a bee. Well, there goes the throat. Well, to the hospital we go. All right, let's try not to let that happen again. Okay, so sometimes it's trial and error. You found out, and then sometimes it's because you actually got tested for stuff. All right. Okay. So another um, distributive shock would be neurogenic. Okay, so this would come from brain trauma. Okay, I am a very big fan of brain health. Okay, so it's a big part of what I do in practice is try to promote brain health. So when you look at the current studies and literature and data on the direction the brain is going in our society, okay, the neurodegeneration is definitely increasing. All right, and there's all sorts of things that come with that package, anywhere from depression to Alzheimer's stuff, dementia, side effects of concussions and brain trauma. Okay, so I do this thing called the SCAT3 protocol. Okay, so the SCAT3. Now, keep in mind, I've got more of a sports medicine background, so I deal with a lot of sports injuries, and one of those is brain trauma, right? So, helmet to helmet collisions, um, motocross accidents, skiing at high speeds and you hit a tree, this kind of stuff. And, uh, you really do have to be careful. And I do think that the awareness of brain trauma and concussions is getting better, but there's still a lot of old school people out there, like coaches, for example, right? So two people collide, and it doesn't matter the sport, but there's head to head contact and they both go down. Okay. Coach comes out and they kind of wave their fingers in front of them. How many fingers do you see? 11. Good enough. Even though they were holding up like two fingers, right? And they get back out there and play. It's like, no, don't do that. Like, take them out of the game. Okay. You have to stop. You have to give the brain a rest. All right. So, um, anyway, so brain health is very important. Uh, on paper, it's real easy. If the brain suffers a concussion, you have to take a break. You have to take some time off. Okay. And that would include no television, right? No loud music, no, uh, overexposure to light type stuff. Like, give the brain a rest. Now, if it gets severe enough, they have to go to the hospital and then they have to take care of them there. And there's different levels of brain trauma care. It could be as severe as they have to release the pressure by drilling holes in the skull. Okay. Others is just medication to keep them calm, reduce swelling and stuff like that. But after the hospital stabilizes you and or saves your life, right? Then you have to do more long-term care after that. And really the bottom line is rest, okay, with brain trauma. So the SCAT-3 is a an exam basically that you do on someone, okay? The higher the score, the worse it is. Okay, so a perfect score is a 0. A perfect score would be a 0, okay? So a score of like 180 would be really bad. All right. I don't clear people until they're in the single digits, right? So if you're a 5 or a 3, okay, or a 1 or whatever, once you're in the single digits, depending on the sport, depending on the activity, then you're clear, right? So over the years, people come in a score of 140, right? And as time goes by, we monitor and we do follow ups and whatever. And as the brain is healing and they're feeling better and that kind of thing, and they get down to now, let's say a 3, it's like, okay, you're clear to go back to whatever it is you go back to. Okay. Um, you also have to keep in mind the number of concussions, okay, and the age of the person, right? So 15-year-old athlete, first time concussion, relatively mild, okay, 3 to 4 weeks, they're fine and they can get back to it. So that's their first concussion ever, right? But then let's say 8 months later or a year later, they get a second one. And then a year or two later, they get a third one. You're done. Okay. The brain can only handle so much stuff. Um, I've had those talks with parents, because some of these high school kids come in. It's like, look, this is their third one. You have to stop. What do you want them to be, like 28 years old and severe brain issues? So, brain health, very important. Okay. So, those of you who are going to be dealing with um, brain trauma and other brain health issues, it's really, really important to educate people. All right. So here's the quick version of how it works. Okay. Number one, you got to take a break. Give the brain a rest, allow it to heal. All right. The length of time varies on the severity of the injury. And then the second thing is nutrition. The brain needs lots and lots of nutrition. So they have to stay away from alcohol, drugs, uh, smoking, pro-inflammatory foods, and on the list goes. Okay. So you got to have good brain nutrition. Okay. And, um, you know, which we could talk about this for quite a while because there's so much stuff that comes with brain health, right? Your nervous system's most important system in your body. It functions everything. The brain and the spinal cord function everything. Okay. So, anyway, so if you ever have that opportunity to, work with your patients and work with people, you just do the best you can to get across. You've got to take a break. Let your brain heal. It's the only one you've got. It functions everything, and you've got to take care of it. All right. So brain trauma um, can cause a type of shock, right? Another one under neurogenic is uh, drug overdose. Okay. And then kind of another easy way of looking at this is anything that can hurt the central nervous system. Okay. Anything that can hurt the central nervous system. Brain infections, spinal cord infections, meningitis, whatever. Anything that can hurt your central nervous system can create a type of distributive neurogenic shock. Okay. And then another type of distributive shock is septic. Okay, septic. And really, that's too many toxins. Okay, too many toxins. Infection, right? So the toxins can lead to, well, it is an infection, right? Toxins is an infection, but if the infection is bad enough, it creates problems. So examples would be things like E. coli, pneumonia. Okay. uh, gram negative bacteria. Okay, gram negative bacteria, they tend to release this thing called endotoxins. Okay, and endotoxins, they it causes an increase in cytokine activity. Okay, and anytime you see that, anytime you see cytokine, think inflammation. All right. So with inflammation, you have a million things that can happen. Just tons of stuff. Here's a couple quick ones, right? The interleukins can come in, which promote inflammation, fever, fluid retention, all that stuff. The tumor necrosis factor, okay? The influx of white blood cells. Okay, and all these guys feed off of each other, right? Okay, so we had a question. Does back to brain trauma and brain health? Does PTSD affect the score or just physical trauma? Great question. Let me try to answer that this way. So the SCAT3 protocol, okay, let me back up. One of the problems that we are seeing, starting with the NFL, okay, professional football, and then it works its way down, right? College football, high school, little league football, and then other sports, soccer, um, and so on. So any sport where, you can concuss, it's just been a growing problem. Okay. And in recent years, especially because of lawsuits against the NFL, um, it's becoming more of an, let's just say, education issue, meaning we're trying to educate coaches, educate people, have better protocols, right? Athletic directors of schools and colleges, the directors of all the league sports and that kind of thing, right? Um, and then at hospitals and other doctors' offices and so forth, because you could just be, going for a walk and you stink and fall and hit your head. All right. And you go in, so you don't have an athletic director, you don't have anyone overseeing you except yourself and maybe your family doctor. So it's just teaching everyone to be more mindful. It's like, hey, you concussed, and here's what the post concussion protocol looks like. Okay. So going back to answer that question, does PTSD, um, how does that tie in with the SCAT3 and protocols and trauma? Okay, here's maybe another way of saying that. If you have a pre-existing, if you have a pre-existing condition such as PTSD, it can make your current concussion worse. It takes a bad situation worse. Okay. So the SCAT3 is not necessarily a protocol to assess for past trauma, such as you've been diagnosed with PTSD. Okay. But what it does is it takes into account, the SCAT3 takes into account where you're currently at because of trauma. And you have to use your clinical judgment to bring in what happened in the past. Okay. So, for example, if this is your third concussion, we have a whole different ballgame we're dealing with. If you have pre-existing PTSD, different ballgame to deal with, right? Different protocol. In other words, you're stricter. There's more guidelines to this, right? If a person has, if they're elderly and they have Alzheimer's and they concussed, whole different protocol because of the pre-existing. Okay. Um, by the way, now this is a 20, let me think. I think this is a 2018 statistic. Okay. So every year I go to these, concussion seminars and brain health seminars and things like that. So here it's kind of a trick question. Okay. Um, Here's the question. What is in as far as youth sports, what is the number one concussed sport and athlete out there? Anybody want to take a guess?
Cheerleading.
Okay, you're pretty close. Most
Gymnastics. I don't know.
Okay, super close. Most people say
Football.
Yeah, most people say football. That's what I said in the seminar. Was that's what everyone screamed out. Football. It's women's soccer. Women's soccer.
I believe it. We go hard.
Yeah. Someone said rugby. Okay. So, yes, that is much of it's kind of a surprise, okay, to most people. But once they broke down the studies and the mechanics and what happens, yeah, women's soccer is the most concussed sport out there. I don't mean to laugh at it. It's just you wouldn't think so, but it is. And then here's okay, it's kind of a play on words. So you have to be careful how you read this, right? Per capita, right? Per athlete, what's the most concussed sport? Okay, that's a tough one. No one gets that one. And the answer is bull riding. Okay, rodeo people in bull riding. All right. So, in other words, bull riding is not really that popular of a sport compared to football, baseball, basketball, soccer, all that stuff, right? There's just not that many of those kind of athletes out there. So, because of the small number and how many of them get concussions, that's the number one most concussed sport per capita, right? So, relatively speaking. and I don't remember the numbers, you know, there's probably like 4 million soccer players nationwide and probably like 50,000, you know, rodeo bull riding people. So they all get concussed. It's 100% of them. I mean, think about that, right? The nature of bull riding. Oh, that's crazy. There's one of the guys that teaches the docs that teaches the concussion seminars I go to is actually the team doctor to the whatever the professional rodeo thing is called. Okay. So and then the rodeos people's version of the Super Bowl is in Vegas every year. You know, you have local competitions and all these other cool things with rodeos, but the big one is the one that's in Vegas. And you know, they have a team of doctors that are there just in case. And one of those docs lives up in Fort Collins and puts on these brain health and brain trauma, brain concussion seminars. So they're kind of neat to go to. All right. So back to okay, gram negative endotoxins. Right. So influx of white blood cells. Okay. And all these things create inflammation and, you know, can spin out of control, take a bad situation worse. Okay. All right. One more and we'll take a break. And that would be complications of shock. Okay. All right. So some complications would be acute respiratory distress syndrome. Acute respiratory distress syndrome. All right, so this one is usually seen with septic shock. Okay. And then it happens because of decrease in lung function. Okay, so you have a decrease in lung function. And that is because of white blood cell. Let me try that again. White blood cell influx. Okay, white blood cells destroy. Right, that's their job. They're basically a type of Pac-Man, right? So phagocytosis, they eat the dead and dying debris, and they eat the bad guys, and they fight off infections. But there's byproducts to that. Okay. Activation of proteolytic enzymes. Okay. So when these happen, you're going to get fluid, quote and unquote, leaking. Okay, so you get fluid leaking into the lungs. And this decreases gas exchange. So therefore, decreased oxygen, so hypoxia, and then all the stuff that comes with that. Okay, so acute respiratory distress syndrome. All right, and then we have DIC, disseminated intravascular coagulation. Okay, disseminated intravascular coagulation. Okay, so all this is clot, or I should say abnormal formation. Okay, when that happens, you get decreased blood flow. Okay. And then as far as a lab, you can order D-dimer. Okay. So D-dimer is a protein that is released due to blood clots dissolving in the body. Okay. These are usually ordered stat. Okay. So some complications. Well, I didn't need to do that. That's all right. Okay, so some other complications of shock would be acute renal failure. Okay, and MODS. And we can do a different color for that. So make it stand out better. Okay, so MODS, which is multiple organ dysfunction syndrome. Okay, so MODS usually happens because of trauma. Okay, if it's trauma that causes it, that's called primary MODS. Okay, if it's because of sepsis, that would be secondary MODS. And consequences of the sepsis is the too much inflammation. Okay, and then all of that Usual suspects we've talked about with the recruitment of white blood cells and tumor necrosis factor and interleukins and so on. Lots of fluid byproducts because of it and decreased oxygen. Okay, acute renal failure, and then we'll take a break. You have decreased fluid through the kidneys. Okay, and this is because of vasoconstriction in the kidneys. All right. And this causes a decrease in the GFR. Okay, you can actually do a lab on that to figure that out. So that's the glomerulus filtration rate. Okay, so the heart pumps fluid through the tubes. Tubes eventually have to go through the kidneys. The kidneys, to some degree, act like a big filter. It keeps the good stuff and gets rid of the bad stuff. Okay, that's super quick version of one of the functions of the kidney. Keeps the good stuff, gets rid of the bad stuff. It also helps with fluid balance. Okay, kidneys will help you with fluid balance. So things have to get filtered through the kidney. The pump has to push the fluid through the kidneys in order for this to take place. So if you get vasoconstriction, then you're going to have a lot of problems, right? So that'll affect blood pressure. That will affect fluid retention. Okay, here's another one you can do a lab on. And that would be, you'll have an increase in blood urea nitrogen. Okay, so the urea and the nitrogen should be, you should be able to pee that out, right? But, well, the kidney isn't working. So your body's like, fine, if kidneys, you're not going to work, no problem. I will just keep the crap and let it build up in the blood and create problems. That's what I'll do. So that's what it does. And you can do a measure on that. You can do the blood urea nitrogen lab to assess for that. Okay, the vasoconstriction causes hypoxia, which causes ischemia, which contributes to more blood urea nitrogen, an increase in blood urea nitrogen. All right. Okay, any questions, comments, and all that before we take a break?
Sorry, did you just say vasoconstriction causes hypoxia, which causes ischemia, which increases the BUN levels? Is that what you said?
Well, it contributes to it, right?
Oh, okay.
So it adds to it, yes.
Okay.
All right. So let's take a 15. So I'll see everyone around 11:15. With alterations in gas exchange. So the next, actually several chapters, they all kind of blend together, okay? Because it has to do with, you know, obstruction of the lungs, gas exchange problems, alterations in gas exchange, and so on, right? So they're kind of all in the same family. Restrictive pulmonary, okay? So simply put, the lungs are pissed. And let's dive in and see what's going on. Okay. Whoa. All right, alterations in gas exchange. Okay. Just a really quick reminder, right? You have the lung field, so right and left lung, okay? You've got the trachea, so your windpipe, and the trachea bifurcates and goes into your lung field. All right, just a quick version here. And then those bifurcate and, you know, eventually distribute it and get all the way out there to the alveoli. All right. So anytime you get, you know, if those areas are hurt, whether it's through constriction, through fluid buildup or whatever, you're going to have problems. Now, on the other hand, you can have age related respiratory issues. Okay. So not necessarily trauma, just age. And some of the things that come with the age related would be like a decrease in the elastic fibers. Okay, the lung does have a stroma, and woven kind of within all that is some elastic fibers. Gives the lungs the ability to recoil. They can have an increase in collagen. Okay, when this happens, the chest wall gets stiffer. Okay, I see this a lot in my practice. You know, I take care of some seniors, and a lot of what I do is hands-on, right? A lot of PT stuff, a lot of soft tissue, mobilization, and so on. And you know, when you palpate, let's say the posterior spine, so the thoracic spine and the ribs and the flank ribs, I mean, it's just they can be stiff. Okay, so just a large part of that comes with aging. Okay, they can also have an increase in alveoli size. All right. And what this does is it increases what's called the dead space. Okay, increases dead space. So meaning relative to how much gas is inside of, all right, let me draw this out. So let's say this is normal. Okay, there's the alveoli, and then there's oxygen inside. All right, so there's really not a lot of dead space in there. But theirs is like this. Okay, lots of dead space. So it's a lot more work for the oxygen or gas exchange to take place. Okay. And then they will have an increase in mucus. Okay. And the fun part about that, usually with a decrease in cilia. Okay. The cilia line the respiratory passageway, right? These little hair-like projections, the cilia, line the airway, the trachea, because their job is to move particles away from the lung field. Okay. You know, as we breathe in the air and all that stuff, you know, things can just try to get inside your lung field, and your mucus, okay, your mucus and the cilia are there to protect you. But in some people, as they get older, there's an increase in mucus production and a decrease in cilia. And this can actually lead to or cause a non-productive cough. Okay. My personal term for that, it's just, I call it an annoying cough. Good grief. They just sit there and all day, just and you're like, look, buddy, we got to talk. But it's, you know, as you age, this is so gradual, the onset. They don't, at this point, they don't even know they're doing it. It's literally second nature for them. But to everyone else, it's kind of annoying. Okay, so they just have this non-productive cough like all day long. Okay. All right, now all of this contributes to increased workload of breathing. Okay, so all this increases the workload of breathing, a type of labored breathing. Okay. All right. Overproduction of mucus plus the decrease in cilia plus the narrowing of the trachea, okay, leads to an increase in airway obstruction. By the way, this is for peds. Okay, so the one we did above this was elderly. This is going to be for pediatrics. Okay, so peds. Okay, the cilia, that may or may not be present. Okay, but the narrowing of the trachea, typically because of age, like a premature infant, for example, and overproduction of mucus can lead to airway obstruction. The actual position of the respiratory structures okay, so they could have an increase in the bifurcation of the trachea. Right, so when when there's a fork in the road, right, so you've got a straight line and then all of a sudden it splits, that's a bifurcation. Okay, it's kind of like a fork in the road. Like a snake's tongue, for example, is bifurcated. So they could have an increase angle of that bifurcation. Okay, another one could be the larynx is higher in the neck, or yeah, the neck area, throat area. Okay, the actual positioning of that can cause some respiratory problems. And the glottis can sit higher in the throat. Okay, so with peds, these are just some of the things that they evaluate, right? So what are some structural things, some alterations that are contributing to labored breathing, heavy breathing, or increase in respiratory rate. Okay. This can also increase chances for aspiration. Okay, in other words, something getting stuck in the lungs. Okay, and if that happens, then you risk infection. Okay, so fluid buildup, recruitment of phagocytes, macrophages, white blood cells, etc., and that leads to decreased oxygen, okay, and other respiratory problems. Okay, so things that influence breathing. Okay, influences on breathing. Okay, the recoil ability. So that goes back to the elastic fibers.
Is this still for peds or just in general?
Now this one's just in general.
Thank you.
Okay. Airway resistance. Okay, so the tubes, so the trachea, I'm going to exaggerate this, can taper into a smaller diameter. Okay, as you can see here. Okay, so that can change airway resistance if the tube tapers into a smaller diameter. And that can actually continue as it goes all the way out to the alveoli field, right? So trachea, primary bronchi, secondary bronchi, tertiary bronchi, terminal branches, alveoli, kind of like a tree, right? The more centered you are to the trunk of the tree, big and round, big diameter, and the more distal you go to the end of the branches, the smaller in diameter. Another one can be smooth muscle tone. Okay, so the body, remember the body has 3 types of muscle: skeletal muscle, cardiac muscle, and smooth muscle. Okay, pretty much all the tubes inside of you are smooth muscle: respiratory, digestive, okay, blood vessels, and so on. All right, so it's a type of smooth muscle. And because it's muscle, it can respond, right? They can they can dilate or constrict. Okay, so smooth muscle tone. All right, so some chemical influences can be your beta androgenic receptors. Okay, these promote bronchial dilation. And let's see, also cartilage tone. Okay, so just how well the hyaline cartilage that's found within the trachea with what's the integrity of that, right? So smooth muscle tone and cartilage tone. Another one is Carcedian rhythms. Okay. All right, your circadian rhythms. Now this is interesting. Pretty much naturally for just about everyone, around 6 a.m., you have max bronchial constriction. Okay. And around 6 p.m., you have max bronchial dilation. Okay, just kind of as a natural course of our circadian rhythms. Now, some people, you could say, are just lucky because they're born with smooth muscle integrity, cartilage integrity, diameter integrity, all that. And so it's fine when this happens. But if, you know, the diameter is off and all these other things we've talked about are off, whether it's because it's congenital or otherwise, then, you know, they're going to be more sensitive to it, especially with the bronchial constriction. Okay. So sleep apnea can be a part of this, right? So some people have to be on a CPAP machine. And, you know, there's a lot of factors that go into a person that needs a CPAP. You know, it's typically not just one thing to blame. It's usually all the above, right? It's a little bit of all the above. Obesity, how the integrity of your actual lung and respiratory tissue, pre-existing conditions, you know, diabetic, history of respiratory disease, are you a smoker, you know, that kind of stuff, right? So there's a lot of factors that can go into influences on breathing. Okay. You also have lung compliance. Right. Okay. Lung compliance, which is their ability, the lung's ability to expand which means inflate. Okay. Kind of like a balloon, right? Blow into a balloon, it should be able to expand. It should be able to inflate. If it's a poorly made, inexpensive balloon skin, the compliance won't be very good. If it's a well-made balloon skin, then the compliance will be impressive, right? The ability to expand and or inflate. Okay, and then another one would be body position. Okay, so upright versus supine. Okay, supine is like you're laying on your back or some sort of recumbent position. Okay, meaning some form of laying down. Okay, so upright, ventilation takes place. So you have increased ventilation at the base of the lungs. Okay, so that's the bottom part of the lungs, closer to the diaphragm. So all that base area of ventilation tends to be better down there in an upright position. In a supine position, the ventilation is what's known as the dependent part of the lung field. Okay, so probably the easiest way to visualize this is the lowest part of the lung field in relation to gravity. Okay. All right. So your water bottle analogy would be good for this. Okay, so here is your water bottle, right? And you fill it, and the water bottle right now is upright. And if you fill it with fluid, because of gravity, the fluid is going to settle toward the base or the bottom of the water bottle. Okay. If you take this water bottle and tip it onto its side, right, as you would imagine, the fluid will change in relation to gravity. The lowest part of the water bottle field or the lung field in relation to gravity. So the fluid should do something like this. Okay. So that would be now the area of the ventilation dependent on the part of the lung field in relation to gravity. Okay. So some people have, because of this, and just for whatever reason, whether it's the way they're built, pre-existing conditions and whatever, they have a hard time sleeping on their back because of breathing. But they'll tell you, like, I do better when I'm on my side or I'm on my stomach. Okay, or I do better when I sit like in a lazy boy chair because they're more upright. Okay, in a hospital, you may have to change the angle of the bed because of breathing patterns. Okay. Neurologically, okay, neurologically, you have the medulla, right? Like the medulla oblongata, so part of the brain stem, and the pons. Okay, the medulla allows for inspiration and expiration. Okay, and the pons controls the rate of breathing. Okay, so most adults, I think, are around, so about 12 breaths per minute. Okay, resting, right? A resting of around 12 breaths per minute or so, right? Could be 10, could be 15, but around 12. So, and then once you start running or exercising, because of the changes in gas exchange and oxygen and CO2 demands, the tick, the spark to the brain goes up, right? So as a result, you breathe faster. So that's one of the reasons why respiration or breathing, the rate of breathing changes once you start exercising. Okay, so have you ever noticed, now no one ever thinks about this, so it's kind of a play on questions, but think about it. Ever notice, why do we breathe in but not continue to breathe in? It's not like people inhale and then they keep inhaling and keep inhaling, and then all of a sudden they inflate like this huge balloon and float away. Like, that doesn't happen. And nor do you exhale and continue to exhale and continue to exhale until you're completely deflated. Like, it just doesn't happen. So at some point you breathe in and then it just stops, and then you go the other way. You breathe out. Okay. That has to do with a stretch reflex that the medulla picks up on, that at some point, because of the expansion of the lungs and the ribs and the diaphragm and all that that goes with the breathing package, okay, they stretch to a certain point and the medulla just knows, because of a stretch reflex, to now go the other way. And now you breathe out. And you don't just continually breathe out. At some point, you just stop breathing out and then you breathe in. So then it's inhale, exhale, inhale, exhale. That's the medulla. And then the pons sets how many times you do that in a minute. So if you are resting, everything's calm and cool, let's just say it's about 12 breaths per minute. Okay. And if you start exercising to the degree of your aerobic or whatever exercise, like sprinting versus jogging or brisk walking, will be to the degree of how many breaths per minute you're going to take. Okay. Okay. Virchow's triad, right? So tri is 3. Okay. One can be because of venous stasis. Okay. And this can be because of dehydration. Decreased blood circulation. People that are at risk for this, and the hospital, future hospital workers will see this quite a bit. And that will be like bed rest. Right? Immobility or bed rest, people that they're just in the hospital bed, or hospice care, they're in bed, whatever, maybe an assisted living place. Okay. This decreases circulation, which will affect pulmonary. Oh, by the way, this is pulmonary embolism stuff. Okay. So Virchow's triad has to do with risk factors for pulmonary embolism. Okay. Stasis is a state of not moving, right? Static or stasis. Dynamic, ideally, is what we want. You want the body to be moving. A sedentary lifestyle is overall just not good. Okay. So some form of movement is necessary. Otherwise, you can create problems. Okay. So one of the three is the venous stasis. Also, congestive heart failure can contribute to venous stasis or decrease in blood circulation. All right. Another factor for pulmonary embolism, hypercoagulability. Okay, I just broke the word down for you. Hypercoagulability. All right, risk factors for this, hormone replacement therapy. Okay, the most common being estrogen. Okay, smoking or thrombus disorders. Okay, and I'm going to put in here genetic or environmental. Okay, environmental is my particular term for you kind of did it to yourself. Okay, you can't help the genetic stuff, but there's a lot of environmental things we can control. Like you don't have to smoke, and you don't have to do, certain things to your body and to yourself that would put you at risk for getting blood clots. Okay. Sure, certain things environmentally you can't help, but a lot of it you can. Okay. But either way, that can happen. Okay. Another one would be blood vessel injury. Okay. Blood vessel injury. So that would be, let's see. So tunica intima injury, right? So remember the 3 layers of a blood vessel, the tunica intima, which is the inside most layer, you want it, that's made of simple squamous epithelium. You want it to be smooth and continuous. So if it gets hurt, then you're gonna you increase your chances for a thrombus to develop, and then eventually an embolus. Okay. So how can you hurt the tunica intima? Glad you asked. Trauma can cause it. Burns. Post-op. Okay, so post-operation. Catheters. And then lifestyle. Okay, such as nutritional deficiencies that hurt the integrity of the blood vessels so they become dry rotted, right? Atherosclerosis, arteriosclerosis stuff, systemic vascular disease, you know, diet, life, that kind of thing, right? So anything that can hurt, chronic inflammation, things that can hurt the blood vessels, specifically the tunica intima, right? So what happens is in the tube, right, in your blood vessel tube, as blood is traveling through, there is friction against the wall of the tube, okay? So laminar flow is what you want. But what happens is once you get some sort of tunica intima damage, as blood is flowing through, you start to nick and spur the red blood cells, so they get hurt. And then you get platelet activation, you know, you get all the thrombus stuff and the fibrinogen and the fibrin and on that goes, right? The platelets get sticky and they aggregate. Plus there's inflammation, so your inflammatory mediators come in, and as the inflammation stuff is coming in, it picks up everyone. Hey, come on, everyone, just join me, just piggyback, and let's go in and create as much of this as we can. Yay, right? Thrombus, and then that can break free and turn into an emboli and go to the lungs, right? Go to the brain. That's wonderful. But since we're looking at respiratory stuff as part of Virchow's triad, you can get a pulmonary embolism because of that. Okay. So other things that will influence respiration, and this is not a fun one at all, and that is lung cancer. Okay, cancer is never fun. So, but lung cancer, you can get a squamous cell carcinoma. Okay, squamous cell carcinoma. All right, this one usually takes place at the hilus or hilum of the lung. Okay, so the hilus or the hilum means like root pluck. So if you ever, let's say you go up to a sapling tree. Okay, so there's your sapling tree with some leaves and stuff on it. And there's the ground, right? So underneath the ground, you've got the root system. And if you pull this tree out by the roots, then it kind of, you know, you're looking at the roots, right? So that area is called the hilus, a root pluck system. So in your lungs, okay, in the lung field, you've got the primary bronchi that goes in, plus there's your heart, right? And you've got lots of tubes and nerves and just all sorts of wires and so forth coming in and out of the hilus of the lungs. Okay, the kidney has the same thing, right? So as all these tubes are coming in and out of the kidney, that area is called the hilus. Okay, that's where it gets its name. It's kind of like a root pluck. Okay, so that's where they get it from. So the squamous cell carcinoma typically likes to develop at the hilus of the lung. Okay. Most common reason. So most common reason is smoking. One of my favorite sports medicine docs who practices in Pennsylvania, travels all over the world actually doing sports medicine seminars. You know, it works on high-end athletes like Derek Jeter, was part of the team working with Peyton Manning back in Manning's day when he had the neck surgery and the atrophy of the arm and the shoulder, couldn't throw a football, and on and on. He tells you all sorts of stories. Olympians, professionals, you name it, he works with them. So good stuff, right? And but here's the thing. All the fancy stuff that he and the team does that works with high-end athletes, here's what he tells everybody in the seminar. It's just his thing. He goes, get your patients to stop smoking and stop running. Out of the million things you could pick, that's the two that apparently annoys him the most. Stop smoking, stop running. Now, keep in mind, you know, someone like that, knee replacements and all sorts of knee things that they deal with usually because of running, some form of running, right? And just because they see so much trauma to the knee because of running, that's one of the reasons why, just kind of you can tell he says it in fun, right? But at the same time, serious. Get everyone, stop smoking, and stop running. All right. Then you have the adenocarcinoma. Adenocarcinoma. All right, this usually affects the periphery of the lung. Okay, so the more distal aspects of the lung. Oat cell, also known as small cell carcinoma. Okay, this one is usually found in the central bronchus area. A sign and symptom on this one will be wheezing. Okay. And it can be due to a chromosome 3 damage. Okay. And then you have large cell carcinoma. Okay, now once you start seeing things like large cell, small cell, oat cell, in the pathology world, one of the things that pathologists do is they look at tissue under a microscope. Okay, so somebody does a biopsy, in this case of the lung tissue, but you can biopsy skin, muscle, you know, the thyroid, whatever. You can biopsy anything, and you send it to the path lab. And just over the years, as you know, they discover things and research, and you know, so sometimes they come up with descriptors and modifiers, and sometimes they keep it that simple. Well, this is very large, so we'll call it a large cell carcinoma because that's what it looks like under a microscope. Or it's small, okay, and they look like oats, so it's where it gets its oat cell. Sometimes these things are named after the person that founded it. Like, for example, if you find Lewy bodies, which is typically found in the basal ganglia of the brain, and that would indicate you are now flirting with Parkinson's disease or you have Parkinson's disease. Okay, so they would call that Lewy bodies. All right, so large cell carcinoma is because they look large under a microscope. And this one also will develop in the lung periphery. Okay. All right, on this next one, I'm going to pull up chapter 22 PowerPoint. Okay, so that should be under your module. Okay, if you guys want to take a minute to access the obstructive pulmonary disorders, it should be titled chapter 22. I'm going to do a screen share with everyone real quick. So we're going to move away from handwritten notes and get back to PowerPoint stuff. As bronchial dilation or tube dilation. Okay. So you have the intrinsic version of asthma, okay, non-allergy response. And then you have extrinsic, which is typically an allergy response, all right? So intrinsic, non-allergic reasons for getting asthma, extrinsic, allergic reasons. IgE is the culprit here, right? So we talked about that a little bit ago, where once you activate and recruit too many of these IgEs, then you're going to create the classic inflammation and inflammatory response. Okay, so in the lung field, with this particular case, it would be asthma. Okay, the intrinsic, usually adult onset, so develops in middle age. Person will have no history of allergies. Okay, past infections might be a factor. All right, exercise-induced asthma. Okay, the bronchi start to spasm, usually pretty quickly after you start exercise. Okay, And then things that may not help. And since I do, you know, sports medicine stuff, I actually see a lot of this. So staying hydrated. Also, we try to get them away from pro-inflammatory foods. And I'm just going to put things. Okay. Pro-inflammatory foods or things. Sometimes, you know, a kid's parent or parents smoke, and they're around secondhand smoke, which can provoke the child's respiratory system. So that doesn't help. So that's worth having a conversation over. Now, between me and you, that one I don't really understand. You know, if I was a smoker, which I'm not, but if I was, I just would not do that in front of and around kids. Hey, kids, come into this confined space and let me smoke around you. Like, I don't get it. Just go outside or go somewhere else, you know? So, anyway, and then pro-inflammatory foods. This is actually huge, by the way. Okay. So we don't really have time to get into the whole cascade of events. All right. But here's the quick version. If you consume something that is going to create inflammation in your body, then something not good is going to happen. So when you remove the provocative factor, in this case, you're removing the provocative foods, it actually helps tremendously. Okay. Now, I like to test for these things through the antigen antibody. So it's very accurate. We are getting into your immune system, and your immune system, your immunoglobulin E's, are telling us exactly what the heck is going on and how we can avoid anything that is provoking you. Okay. So I'm not saying it cures it, but it helps tremendously. All right. Okay. Occupational asthma is basically where you work. So the work environment. Okay. And as you can see in the picture, you know, you can kick up dust, you can kick up all sorts of byproducts from, you know, depending on the nature of the work environment. And it doesn't have to be, you know, dust particles like that. It can be chemical, you know, working in a paint factory or dealing with solutions that have very, very strong fumes can mess with the respiratory system. Drug-induced asthma. Okay, so side effects of medication and food additives. So this would go back to watching what you eat, so diet and lifestyle. All right. I am a big fan of trying to eat clean, and eating clean would mean sticking with more whole food things, you know, fresh fruits and vegetables, lean meats, staying away from artificial foods, staying away from fast foods, excessive sugar, candy, you know, junk, that kind of thing. Okay, because all the stuff that they add can provoke the system. You do get edema that comes in, so swelling. You activate mast cells. So in other words, Pac-Mans come in, like neutrophils and eosinophils and lymphocytes, because once you start the inflammatory process, okay, you're going to recruit a lot of things. And the inflammation can lead to bronchoconstriction, okay, excessive mucus, production and even mucus plug formation, right? Thickening of the basement membrane. So all this stuff decreases your airway. So you go from nice and big and open to not very fun, and that is not happy. Okay. So different medications can help. So they can, block the histamines, right? So you can inhibit histamine production. You can slow down the infiltration of the inflammatory mediators, so anti-inflammatories. Okay. Steroids. Okay, steroids can help. All right, acute bronchitis. So there's a key word there, acute, happening right now. There's itis, inflammation of, and inflammation of what? The bronchi. All right, so it could be viral. Okay, it doesn't have to be, but it could be because you're fighting something. Excessive heat exposure. Okay, smoke inhalation, inhalation of irritants. Okay, so things that can hurt you. Okay, with acute bronchitis, the pathways become inflamed and then they start to narrow. Okay, and then you're going to get swelling and excessive fluid production, increased mucus. Okay, all that contributes to difficulty breathing, difficulty with gas exchange. The cilia lose their function, right? So they're supposed to move byproducts and particles away from the lung field. Okay, with chronic bronchitis, right, key word there is chronic. This is typically years in the making. Okay. So smoking, constantly being exposed to infections or having infections, genetic disorders can lead to it, and then the inhalation of physical or chemical irritants, especially over a prolonged period of time. Usually a work-related thing can cause chronic bronchitis. Okay, so it's chronic inflammation, and I think I've mentioned this before. Chronic inflammation with anything is not your friend. Never is a good thing, no matter what tissue we are talking about. All right. And for these people, because it's usually there for so long, you're going to get new cells, so hyperplasia of bronchial mucosa. So the walls become thicker. Okay, with emphysema, considered a type of COPD, so chronic obstructive pulmonary disease. It's where the alveoli, right? So here's your cluster of grapes. The alveoli become fibrotic. They become damaged. Okay. So fibrosis is kind of a fancy way of saying scar tissue. All right. So they have abnormal enlargement, and typically this is not reversible. So once you get emphysema, it's something you have to manage for forever. Can be a byproduct of having the chronic bronchitis. Okay, so constantly inflamed bronchi can eventually lead to emphysema. All right, you get a reduction in pulmonary capillaries, which means you're going to have decreased oxygen and gas transfer. The constant influx of your Pac-Mans create damage. So the macrophages and neutrophils. Okay, you start to lose the elastic tissue and lung. Okay, so people can have a certain physical presentation. Okay, now in my world, I have seen this one, the barrel chest and the clubbing of the fingers. Okay, I don't really, being more sports medicine, I don't see a lot of, chronic respiratory issues. Okay, I do have a nebulizer, and we do some treatments on some people, some asthmatics and some other things, if they're willing to come in and try to turn over a new leaf. Okay, what I mean is it's very hard to get a person to come in and say, hey, I've got chronic lung issues and I'm willing to turn over a new leaf, and I want to stop smoking, and I want to change my diet, and I want to start exercising, and I want to start getting weaned off, drugs and all this other stuff just to have a health. Like, that doesn't really happen. That would be nice if people would do that, but that's not really a thing. Okay, it's very difficult to get people to change diet and lifestyle and other habits, right? So, but every once in a while, you'll get someone that's interested. So if they are, then we go down that protocol, right? So barrel chest is where the diameter of the thoracic cage is about equal in distance. So they are so if you look at the person anteriorly, the chest has a certain width. And if you look at them laterally, the chest has about the same width. Okay, that's where the term barrel chest comes in. Clubbing of the fingers, right? So clubbing of the fingers, they just look fat. The tips of the fingers look very fat. So that's why they call them clubbing. Okay. All right, so hang in there. We got a few more, and then we'll break for lunch. Okay, bronchiectasis is the dilation of the bronchial wall. Okay. So here's a picture of that. So here's normal. Then all of a sudden you get this weird dilation of the bronchial wall. And it is obstructive, and it does create pus, right? So suppurative means you're going to get some fluid infiltration. Okay, as with all lung problems in general, it's reoccurring infections, constantly being exposed to inflammation, right? So these are the usual suspects. Recurring infection, constantly having inflammation, and then you have either the genetic side of things or the environmental side of things, right? Things in the air, things you're breathing in, and so on. Okay, so it's destructive. And you always get that, well, not always, but in most cases, you get the excessive mucus production, and oxygen does not like to go through thick fluid. Okay, so the thicker the fluid, the more the oxygen is inhibited from diffusing through. All right. Bronchiolitis is the widespread inflammation of the bronchioles because of an infection. Okay, it could be viral that causes it, especially in kids. So one of the more common reasons in kids is viral, and in adults, it's smoking, environmental factors, toxic fumes, breathing in things you're not supposed to breathe in, whether it's work-related or otherwise. Okay, obstruction, right? So you get some sort of foreign object that is stuck in the trachea. Historically speaking, if you're going to get something stuck, it does like to favor the right primary bronchi. Okay, it does like to favor because the right primary bronchi is more vertical. So the right side versus the left. Okay, the right side is more vertical. And let me do that better. And the left side is more horizontal. Okay, because of the way the heart is positioned with respect to the lungs, it changes the angle of that left primary bronchi. And so as something is going to go in, they like to take the path of least resistance, so they usually favor the right lung. Of course, the left lung can get hurt, but overall, foreign objects and all that like to go into the right primary bronchi. Okay, croup is inflammation of basically everything in the throat, right? The larynx, the trachea, the bronchi. Usually because fighting an infection, usually viral. Okay, they have that barking seal cough, kind of a classic sign and symptom of croup is a barking seal type cough. Okay, epiglottitis, right? So inflammation of the epiglottis. This would create hoarseness, right? So you likely would be able to talk with this one. Okay, this can develop after a bout of croup, right? So you're looking at normal here, and that would be inflammation. So as you can see, air would not pass very nicely through the epiglottis and that throat area, right? You can actually see the vocal cords there. Okay, so ways you can test someone. Spirometry, so they breathe into a meter and the computer will pick up on the forced vital capacity. So it's the total volume of air that you just exhaled. Okay, and it will pick up on it's just where you're at, you know, with diagnostic tests with oxygen and CO2 and different byproducts. All right, any questions or comments or anything before we break for lunch? Okay, so we'll come back at about, let's do 1:05. Okay, so 5 minutes after 1, get about an hour in, and then we'll pick up with other restrictive pulmonary disorders. Okay, and so on. All right, so see everybody in about an hour. On X-ray, okay, sometimes these are visible on X-ray. Okay, pneumonitis, right? So not typically found in smokers, oftentimes a side effect of where you work. Okay, there can be a genetic predisposition and an antibody complex. Okay. There's a doc out in West Virginia named John Cannell. Okay, Dr. John Cannell. Interesting story on him. Okay, with inflammation of lung tissue with occupational lung disease. all right, from inhaling dust. Like one of the things you can get is black lung, for example. Okay, black lung. And so what the story behind John Cannell, by the way, if you look him up these days, he's an expert researcher in vitamin D. Okay, so health benefits, but that's not how he started out as a medical professional. He started out by wanting to help miners and other people that worked in, you know, some sort of digging. You know, miners would be the best way of just describing it, because of the lung disease that they can get. Now, the so-called coal miner's lung, anthracosis, what he discovered is these people actually to some degree want to get this, you know, because of the nature of the job, they get disability. So once they get diagnosed with black lung, then they get on disability, and that was their retirement. Okay, so he even tried to fight that. This was back in the 1970s politically, and nobody was on board with it. So he switched gears and started doing research in vitamin D. But there's still people out there that have occupations where, you know, the lungs will get hurt from what you inhale. Okay, silicosis from inhaling silica. Okay, all these will lead to a type of granuloma, you know, that you can see scarring in the lungs. Inhaling asbestos, right? It's supposed to, you know, I guess in the old days they would spray that inside of buildings. I think it was a type of fire retardant, but that is known to cause, you know, lung cancer and other issues. Okay, we talked about that. So we talked about atelectasis. I mean, acute respiratory distress. Okay, infant respiratory distress is the lack of a surfactant, right? So that's the lack of lubrication in the lung field. Okay. Okay, pneumothorax is excessive air or abnormal air accumulation in the pleural space. Okay, it can happen spontaneously, or it can happen because of pre-existing pulmonary disease. Okay, or it can happen because of trauma. Okay, so it's characterized by, you can see the air in the lung there. Okay, so air on X-ray has that kind of black cloud appearance. Okay, you can see the lung is, because it changes in atmospheric pressure, is collapsing. Sometimes with pneumothorax, it's wait and watch. It can self-seal and self-heal. And if not, then they will change the pressure by adding a type of stent, kind of like a surgical straw, okay, to get some of that air out so the lung can reinflate itself. Okay, the other thing you're worried about with pneumothorax, so here's a lot of air getting into the space, kind of shriveling the lung like a deflated balloon, is you're worried about compromise of the heart. Okay, so if there's enough pressure, you actually get changes in the primary bronchi and its relation of the lungs and the heart and the way it sits. Okay, so that'd be something that you're worried about. You can compromise cardiovascular system. Okay, pleural effusion. Usually where fluid gets into the lung space, okay, the pleural space. Okay, you can oftentimes hear this when you auscultate it. It's a type of friction rub. Okay, a distinct sound that the excessive serous fluid makes as it's kind of rubbing against itself as the person breathes in and breathes out. Okay, here's an example of what pleural effusion would look like. Okay, you get fluid buildup in the lung space. So if you are auscultating a lung and you take the stethoscope and you only listen to, say, the upper portions and you don't go low enough, you might miss it. Okay, so don't forget the lungs go down pretty far on the person, right? So don't be afraid to take that stethoscope and, auscultate or listen pretty far down on either on their chest area or on their posterior thorax. Okay, so with pleural effusion, you've got the transudates, all right, usually associated with heart failure. Okay, the exudates associated with malignancies and infections. Okay, the hemothorax, which is the presence of blood in the pleural space, usually because of trauma. Okay, the chylothorax or lymphatic, excessive exudate because of trauma. Okay, poliomyelitis, right? So a virus causes the problems. Okay, that starts to affect the motor nerves of the spinal cord, right? So on your spinal cord, you have that butterfly-shaped gray matter. Right? And then you have the sensory, right, that goes in and up to the brain through the dorsal columns. Okay, if you remember back from neuro, your fasciculus cuneatus and fasciculus gracilis. Okay, that's sensory. And then you have motor that comes down and hits the anterolateral system. No, not the ALS, sorry. That hits the motor areas of the cord that goes out of the anterior nerve root, right? The anterior or ventral horn. So the virus hurts the motor areas of the cord. And because of that, because of motor loss, okay, start to have weakness, a type of paralysis, and breathing failure. Breathing takes a lot of muscles, diaphragm, intercostal muscles. Okay. There's a picture of an iron lung for you. So a type of decompression for oxygen. Okay, amyotrophic lateral sclerosis, ALS, also known as Lou Gehrig's disease. All right, so the lateral area of your cross section of the spinal cord, right? The lateral area starts to die. Right, so that's why one of the reasons why it gets its name, lateral sclerosis. Degenerative disease of the nervous system. Okay, your upper and lower neurons get hurt. Causes muscle weakness, and eventually your respiratory muscles start to fade as well. Okay, so this is a classic Lou Gehrig's disease. All right, Guillain-Barré. Typically proximal shoulder and girdle weakness. Okay, so the proximal shoulder and girdle, so the shoulder area and where the hips come together, weakness. Okay, so they have a hard time walking. So it's a type of paralysis. Okay, it can also affect the respiratory muscles. Sometimes they can self-resolve. It can be a side effect of medication or a side effect of having a viral attack, but it can also become more permanent with demyelinization. Okay, your myelin is what the electricity travels on, right? So it's like the part of the white matter in the spinal cord. Okay, so electricity travels very nicely and very quickly along myelin, but if you experience demyelination, then you're going to start to have some paralysis and other weakness problems, including respiratory. Okay, myasthenia gravis is, so you have a nerve. Okay, so this is the presynaptic. Okay, and then you have the post synaptic tissue. Okay, and there's receptors on the post synaptic tissue, and those receptors are they're blocked or they're damaged. So as the neurotransmitters are trying to cross from the pre to the post synapse, they can't bind to the receptors, which this particular one creates the myasthenia gravis. Okay, so if the receptors aren't binding, then you're going to get weakness. Okay, so a classic sign is the droopy eye. It's a hallmark sign and symptom. And of course, respiratory muscle weakness. Okay, so it can affect breathing. Okay, so a severe type of kyphosis. All right, so in your spine, you have the cervical curve, right? So there's the skull, there's the nose. Then you've got the thoracic curve, right? And then you have the lumbar curve. Okay, so cervical spine is supposed to have a lordotic curve to it. And the thoracic spine has a kyphotic curve. All right, the lumbar spine, and this is from a lateral view. So if you look at a person, look at their spine from a lateral view, like let's say you take an x-ray, you want to see a curve in the neck. It's called a lordotic curve, right? A curve in the thoracic spine, a kyphotic curve, and then a curve in the lumbar spine, also a lordotic curve, and then in the sacrum, which is, you find another kyphotic curve. Okay, so that's normal. All right. If this becomes excessive, then it's kyphosis. All right, so it's like a type of hunchback, so to speak. Okay, and then scoliosis is like an abnormal bending of the spine. So it's bone deformity, okay, usually in the thoracic area, that starts to compromise the ribs, right? Because, you have 12 thoracic bones and 12 pair of ribs. Okay, so if your thoracic spine is all bent, okay, like this, okay, it's bent too much, then you're going to compromise the lung field, okay? And then if you have scoliosis to go on top of that, it makes it even worse. Now, some people have scoliosis only, right? They have scoliosis only. They do not have the kyphosis. Some people have only the kyphosis and no scoliosis. And then others have both, okay? So the worse the angle, the worse the angle, the worse it is on your lung field, your ribs, the heart, the respiratory system. Same with scoliosis. The worse it is, the harder. Okay, and I do see scoliosis cases. Kind of in general, your rule is so 0 degrees would be perfect. So 0 to 10 degrees is not really that big of a deal. Okay, 10 degrees to 30 degrees becomes a big deal, and anything greater than 30 degrees curve can start to cause a lot of problems. Okay, so for example, if you're dealing with somebody with, say, a 60-degree curve, that's awful. Okay, that's really bad. Okay. Usually under 30 degrees, conservative management can help. Okay, you don't have to do surgery. But the bigger the degree, so 35, 40, 45, 50, and so on, those are definitely surgical consultations, and sometimes they have to insert rods or whatever to try to help you out. Okay. I get that a lot. You know, people come in, they have a 10-degree curve. Do I need surgery? It's like, no, it's not bad enough. Okay. But then at some point, yeah, it gets pretty bad and you will probably need it. Okay, ankylosing spondylitis, also known as AS. Okay, it's an autoimmune disease characterized by the human leukocyte antigen, so HLA-B27. That's the lab that you do to find out if you have it. Okay, it's a type of arthritis that affects the joints. It's also known as bamboo spine. Okay, if you look at that, kind of looks like the bone is turning into bamboo. Bamboo has a certain look and characteristic to it. So this slang is called bamboo spine. Okay. So it's chronic inflammation. It's a significant type of arthritis. It hurts. It starts to degenerate usually from the hips, and it works its way up the spine. Takes a long time to affect the person. Okay. And, you know, in other words, this is over the years, right? And every year that goes by, it just gets worse and worse. And then once it gets into the thoracic area, it starts to compromise the ribs. And basically, the ribs lose their expansion ability. So it's hard to breathe. You know, if you take a deep breath in, the ribs go up and out. And when you exhale, the ribs go down and in. So in other words, the ribs move. And if they're all frozen because of a type of arthritis where it kind of cements everything together, then you lose that function. Okay, so that can cause some chest wall deformities and compromise the respiratory system. Okay, flail chest, usually from multiple rib fractures. Okay, so chest wall trauma. And these things can literally float around. It decides, oh, I'm going to move left lung that way and move the right lung that way. Okay, so the flail chest. Okay, obesity can actually create hypoventilation and airway obstruction. Sleep apnea is often associated with obesity. Okay, just too much tissue surrounding the respiratory passageways, creating obstruction. Okay, pneumonia, a very devastating condition. Oftentimes it is hospital acquired, which means nosocomial. Okay, so a person goes in because of a broken arm and they walk out with pneumonia, right? So one of the iatrogenic, so hospital caused things that can happen. So, you know, you just got to be very careful. when you go from one room to another, change the gloves, wash the hands, usual stuff for decreasing the transmission of anything from one patient to another. Okay, so pneumonia can be caused by bacterial, viral, right? So excessive inflammation in the alveoli. Okay, SARS, acute respiratory or severe acute respiratory syndrome, right? Usually viral related. And, viruses like to transmit from person to person, usually through respiratory droplets. Okay, coughing and sneezing are some classic. We're certainly in those times right now. If you're at Costco and you're 30 people deep in line, just sneeze. They will clear out of the way and you'll get right up front. You'll be first in line. Okay, I'm kidding. Don't really do that. But, right? So, of course, the buzz with the latest viral stuff that's going on, people, I think, are becoming more aware of the importance of washing hands and just being more mindful of staying home. Good grief. Before 2020, right? Before March of 2020, man, people, they just go everywhere. They're so sick, right? They just leave the house. The kids, they drop kids off at school and teachers are, your kids, oh, boy, green snot. Wow, no, it's allergies. But now today we're a little bit more mindful of that. And, I would say it's common sense, right? If you're symptomatic, if you have a fever, if you have a cough, if you're having some exudate or productive cough, mucus, just stay home, right? Stay home. And if there's enough red flags, you go get checked to see what's going on. Okay, tuberculosis. One way to detect it is through X-ray, right? So you can usually see the evidence of tuberculosis on film. Okay, you can also do the skin prick test to look for reactions if a person has TB, right? Usually, if you're at high risk, if you've had prior infections, and then a big one here is being immunosuppressed, right? So once a person becomes immune compromised, and there's kind of two ways of that. Well, there's more, but we'll summarize it in two ways. Okay. One way to become immune suppressed is you did it to yourself. Malnourished, so poor nutrition, lack of sleep, lots of stress, okay, excessive cortisol and all the other stress things in your body is being released. Okay, that's immune suppressant. And you are now at risk big time for, different opportunistic organisms such as tuberculosis. Okay. Another one is just for other health reasons like AIDS, right? That just devastates your T cells and other immune cells in your body, and you become immune compromised that way. Another one would be immunosuppressed drugs, right? So sometimes people are on those things and they just have to be really careful. Okay, the next one would be chapter 24, fluid and electrolytes and imbalances. All right. I work a lot with this one because of, when you see sports type people, I would say a very common problem is dehydration. So not enough good fluids and certainly not enough electrolytes. Okay. So we also live at altitude. So we have an arid, drier environment. So it's very easy to lose fluid to our environment and you don't even realize it. Okay. So it's basically abnormalities in body fluid. Okay, we do have fluid outside the cell. Okay, about 1/3 of all fluid is outside the cell. And then about 2/3 of the fluid is inside the cell. All right, so we can drink our fluid. Okay, you can even eat fluid by, like if you have fruit and vegetables, those are hydrated, right? An apple, watermelon, all that stuff, that's got water and fluid in it. Okay, so you can drink it, you can eat it. Okay, you can be given fluid. We also lose fluid through our skin, breathing out, peeing, sweating, and so forth, right? So there's lots of ways we can lose fluid. Okay, I'm not going to spend too much time on the normals. Okay, this is just a review of some stuff. Hopefully you got in ANP2. Evidence of likely dehydration, lightheadedness, dizziness, okay, orthostatic hypotension. If it's really bad, hypovolemic shock. Okay, we talked about that earlier. And headaches. Boy, I see a lot of this. I see a lot of headache people, right? If you do a good enough interview, also known as a history, you realize, found the problem. Yeah, okay. Just, you're very dehydrated. Let's see what happens if we can get you hydrated again. Okay, now listen, not every headache is because of dehydration. A million things can cause headaches, but sometimes it's as simple as they're just dehydrated. Okay. All right, one of the big concerns with dehydration is sodium. Okay, so your sodium is below the normal limits. And you can actually over drink water. Okay, this one's a little deceiving. You can over drink water. What happens is inside your body, okay, so we'll kind of pretend your body is this cup right here. You have all these dots represent the sodium. Okay, what happens is as you're exercising, daily activities, whatever, your body's utilizing this stuff, right? Your body burns through fuel. It uses the sodium, it uses calcium, all these things, uses magnesium. Well, you start to lose sodium. Then what happens is people are like, oh, I'm thirsty. So they put more water into their body, which takes what little sodium you have left and dilutes it even more. So way more water than you have salt. Okay, so that's why electrolyte drinks and a balance of electrolyte drinks and or food come into play. Okay, so in other words, I'm a huge fan and I promote it all the time. Stay hydrated through healthy fluids. Okay, water is one of them. But you also want to make sure you throw in there some electrolytes from time to time, okay? And that could be like coconut water, orange juice. If you have a pretty good diet on fruits and vegetables, you're going to get your electrolytes that way, okay? And this is just daily activity, daily living things. If you are an endurance athlete or you like to do 14ers or you go on long hikes and stuff like that, you got to make sure you take your water and your electrolytes. Okay. Now, usually active people, they have a grip on this. Okay. If you're new to activity, there might be a learning curve to it. You know, you go out, it's like, whoa, that sucked. I didn't do anything right. Didn't dress right, the wrong shoes, didn't bring enough food, didn't bring enough fluids, but you learn from it, right? So you get better and you educate yourself. So usually active people, they, for the most part, have it figured out. But some people don't, right? So it's just a balance of water and electrolytes throughout the day. Okay. All right. So Na is sodium. So if you don't have enough sodium, your cells can swell. All right. And this creates, you know, kind of going back to this picture here, you're diluting what sodium you have left, right? Hypernatremia, so there's your Na, right? So Na is sodium. So you have too much sodium in your body. And you can become thirsty, you know. I'm guilty of this, and I think some of you are probably too. Let's say you have like Chinese food, right? Super saturated with tons of sodium. And then you'll notice, like in the middle of eating or when you're done, you're just so stinking thirsty. And you're probably just like, I've never drank so much water for dinner in my life. Well, it's because of the 4,000 milligrams of sodium you just had because of the nature of the food. Okay. A nephrologist friend of mine calls it a salt bomb. All right. So he's a nephrologist. And so obviously sees lots of kidney disease and kidney problems in people. And that's one of his expressions is he calls it a salt bomb. When you eat out, okay, you have very little control over the ingredients and all of that that's put in food. Okay. In general, restaurants and manufacturing companies and all that overload the food with spices and salt and whatever. You know, some places will even add the MSG. And then once you get into your fast foods, they add additives, preservatives, and so on. Okay. So you got to be real careful when you eat out. It is best to prepare your own meals. But I also understand, you know, that's sometimes difficult for people and sometimes not an option. But then you just do the best you can if you have to eat out. Okay. Just keep in mind, chronic exposure to so-called salt bombs is hard on the body, hard on the kidney. Okay. It can be as simple as you're thirsty. It will decrease urine output as your body is trying to hold on to fluid. Okay. So the salt concentration isn't so much. If it keeps going, you can be confused, can cause seizures, can put you in a coma, can even result in death. Okay. Hypernatremia causes the cells to shrivel. Okay. Edema is simply excess fluid. Okay. So just about any area of the body can get edema. Usually a side effect of inflammation. Okay. So you got protein that starts to leak out because of the blood vessel's ability to be permeable, right? So you have a blood vessel and the things that are inside can exit the blood vessel. So a type of permeability. This is also where you would like for your lymphatic system to kick in, right? Because lymphatics help absorb excess fluid and excess edema. But sometimes this doesn't work in people's favor. So you get excessive fluid buildup over time. All right. So as different particles and different things are leaving the capillaries, okay, you're continuing to add to the edema. All right. These are important. Okay. I like these for just overall health and wellness and a balance in diet and fluid intake. There are some specialty drinks that I recommend for people. For example, Gatorade is not really the best go-to electrolyte drink. There's too much sugar in it. Plus, they add food coloring, the yellow and the blue and all that stuff. Which, by the way, that kind of food coloring is a DNA synthesis inhibitor. Okay, so you just want to be careful on how much of the dye. Okay, there's usually red, yellow, and blue. And the reason why they add the dye to food and drink is because when they did studies on this, they found it to be very, very attractive. So this is a neurological subconscious feeding center in the brain attractiveness thing. And so it makes you want to have it, right? So that's why they do it. And this is no joke. I mean, just hundreds and hundreds of millions of dollars are spent on marketing and how to get people to buy stuff. Okay, so here's an example for you. At the grocery store, if you notice, like what, especially if you all have kids, why do they put all the M&Ms and the Skittles and the candy in bright red and yellow and fun colored packaging and bags? Eye level with the kids. Why? Okay. So you're standing out, you're in line trying to check out. And, you're just doing damage control the whole time, right? Now, adults are guilty of this too. It's just as attractive to adults, but adults usually don't go as crazy as kids do when they see that kind of stuff. Okay, go down the cereal aisle. Why are all the kids' cereals, the loud red, blue, and yellow colors, why are they eye level with kids? Okay. And on we could go. I mean, there's a whole strategy behind marketing and the color of food and the color of packaging because they know through neural research it is considered a type of subconscious attractive center to the feeding centers of the brain, and it makes you want it. So don't buy into it. Ever notice kind of in general the organic foods and the natural foods, they're more like earth tone and browns and like stuff that it doesn't just jump off the shelf at you, right? So those manufacturers kind of do that on purpose because they're trying to move away from impulse buying. Okay. Anyway, so with your electrolytes, there's just some not really that healthy of forms out there. Gatorade is actually one of them. Because of the dyes and the too much sugar and all that kind of stuff. Some even have high fructose corn syrup in it. You want to stay away from that. And stick with your more natural ones. There's natural supplements you can take. It's usually like a type of powder. You can put it in your water, shake it up. You can do your coconut drinks, coconut water, orange juice, etc. Right, so you can get it naturally that way. A lot of people, believe it or not, are magnesium deficient. Okay, I put a lot of people on magnesium. It does helps tremendously, can even help you sleep better, help you go to the bathroom better. All right, you do sweat out and get rid of electrolytes, okay? So that's why if you're exercising, it is good to drink water, but you also want to make sure as part of that regimen, you get some electrolytes back in you. If the electrolyte loss goes for too long, vomiting can occur. Okay. Then, eventually they have to come into the hospital if it's too bad, and they start measuring you for different problems to detect. Okay. All right. Not enough potassium. Okay. K on the periodic table is potassium. Do not confuse this with vitamin K. Okay. So K is potassium. Classically, you have your sodium potassium pump, right? So our body needs sodium and potassium. Another one you have to worry about is aldosterone. Right, the hormone aldosterone. Because in the presence of aldosterone, you keep sodium and get rid of potassium. Okay, so sometimes just through hormone dysregulation, this can spin potassium out of whack. Okay, low calcium can be simply because of diet, right? Just simply decreased intake. It will change the action potential. You start messing with sodium and or potassium, you're going to change the action potential. So you're going to get altered muscle function. You're going to get altered muscle function. And we have 3 types of muscle, right? Smooth muscle, skeletal muscle, and cardiac muscle. Okay, so some signs and symptoms. Now, people that are post-op, all right, you'll likely see some of this stuff. They'll be too alkaline. Okay, remember your 0 to 14. 0 is acidic. 14 is basic or alkaline. The body likes to be relatively neutral at around 7. So you can be too alkaline, right? Shallow respirations, okay, so breathing issues. They appear irritable, confused, drowsy, weak. Okay, changes in heart rhythms, very lethargic. Okay, a thready pulse, changes in pulse, and then decreased intestinal motility, right? So they feel all backed up in the gut area. Too much potassium, okay, hyperkalemia, too much potassium, okay, could be because of excessive IV infusion. So you just have to be careful, watch for that. Not being able to get rid of potassium properly. Okay, they will experience muscle dysfunction. All right, so not enough calcium. So calcemia, not enough calcium. Likely poor diet. Okay, vitamin D and calcium do tend to go together, right? So that's a complicated biochemistry on how all that works. But it's not unusual to find a person that's vitamin D deficient and likewise simultaneously calcium deficient. Okay. It could be because of hypoparathyroidism. So your parathyroid hormone or your parathyroids release parathyroid hormone. Okay. And parathyroid hormone likes to go to bone and, do changes in extract calcium from bone. Okay. Also on a side note here, going back to your endocrine stuff, calcitonin, right, puts calcium in bone. Okay, now these are normal homeostatic things, right? Parathyroid hormone and calcitonin, and they go back and forth depending on what your body needs at the time. But prolonged can cause problems. Okay. So too much calcium. This one's hard to do. Okay, vitamin D overdose is hard to do. It is doable, but pretty tough to do. But it is something worth looking into. Okay. It could be because of hyperparathyroidism. So the parathyroid hormone is working too much. Changes in, now keep in mind, you are messing with your action potential stuff. So you're going to have changes in where the nerves and the muscle comes together, right? So neuromuscular excitability. Not enough magnesium. Okay. Could be because of diet, right? Could be because of alcoholism. Okay. Changes to the intestine. All right. Because too much magnesium, so hypermagnesemia, keep in mind, magnesium is also a natural muscle relaxant. Okay. So it can behave like a laxative. So it's one of the things I make sure I tell people, look, if you're going to get on this, you may be going to the bathroom a lot more than you're used to. Okay. Because it does behave as a type of laxative. Okay. Not enough phosphates. So adenosine triphosphate, right? So this is part of the energy that we need. Okay, a person can appear confused, can slip into seizures, coma, okay, impaired cardiac function. Okay, too much phosphate in the blood. So emia, too much phosphate in the blood. Excessive enemas or laxatives. Okay, increase in neuromuscular excitability. Okay. Let me pause this.